Professor Junji Umeno, welcome.
Yes. Yeah.
Yes, well, Professor Umeno is going to talk to us about biomarkers in IBD, an update. Please go ahead.
Okay. Is it okay? Okay, can you hear me? Okay. All right. Thank you. Good morning, everyone. Thank you, Chairman, ladies and gentlemen. I am Junji Umeno from Japan, and I'm very pleased to have such an opportunity to talk. Now, I would like to talk about the biomarkers in IBD. I have no financial relationship to disclose. Biomarkers are objectively measured and evaluated assessments of normal or pathogenic biologic process and or pharmacologic response to therapeutic interventions. Diagnostic biomarker is used to detect or confirm the presence of a disease or condition of interest, or to identify individuals with a subtype of the disease. Monitoring biomarker is measured serially for assessing the status of a disease or medical condition, or for evidence of exposure to medical product or environmental agent. Prognostic or predictive biomarker is used to identify the likelihood of a clinical event, disease recurrence or progression in patients who have the disease or medical condition of interest. This is a slide to an updated treat-to-target algorithm for IBD treatment. Within this algorithm, the authors have selected treatment targets for the short, intermediate, and long term. Slide to confirm that the most important long-term achievable treatment target for patients with IBD are clinical remission, endoscopic healing, restoration of QOL, and the absence of disability. Symptomatic relief has been determined as an immediate goal, acknowledging that this is rated the highest by patients in studies. With the accumulating clinical evidence, serum and fecal biomarkers are endorsed as intermediate, medium-term feasible treatment goals, meaning that at times treatment could be revisited thoroughly based on these tests to facilitate care in the clinic settings. So the importance of biomarker is increasing. This is today's agenda. The first topic is commonly used biomarkers. Invasive methods for assessing disease activity in IBD are not optimal owing to lack of immediate availability, high cost, need for bowel preparation, and associated complications. Biomarkers, which are detected easily by reliable and cheap assays, have obvious benefit for detecting active disease. CRP is an acute phase reactant produced by the liver in response to inflammatory cytokines such as IL-1 and IL-6. Assay to measure CRP is available in routine clinical practice and is cheap. However, its use as a biomarker for IBD requires several considerations. CRP increase in patients with other inflammatory conditions than IBD. CRP is influenced by genetic factors and other patient-related factors. And normal level of CRP do not necessarily correlate with clinical remission. Fecal biomarkers have the potential to detect intestinal inflammation with higher specificity. CarProtecting is a calcium and zinc binding protein present in neutrophil granulocyte, released into the intestine during leukocyte trafficking. Fecal CarProtecting is the most widely used surrogate marker of gut inflammation. Many studies confirm the correlation between fecal CarProtecting and mucosal and histological healing in IBD. Fecal CarProtecting allows to distinguish IBD from IBS, assesses disease activity and response to therapy, and predict disease recurrence. It is stable for several days at room temperature. This is an important point for clinical settings. Its clinical utility is well known, but high variability exists between fecal CarProtecting measurements, preventing the definition of a globally accepted cutoff for the interpretation of fecal CarProtecting results. This slide shows factors associated with fecal CarProtecting levels. Fecal CarProtecting is a marker of gut inflammation, but it is not specific for IBD, as some gastrointestinal diseases, medication, and lifestyle can alter its concentrations. These items are reported to associated with increased fecal CarProtecting levels. So interpretation of fecal CarProtecting values should take into consideration all factors that may influence the fecal CarProtecting results. Historic features of inflammation are associated with clinical relapse in UC patients. This study assesses the accuracy of fecal CarProtecting measurements in identifying patients with histological inflammation and develop a model to predict outcomes of the therapy. As you can see, median fecal CarProtecting concentration are lower in patients who have achieved outcomes of clinical remission, endoscopic healing, deep remission, or histologic remission versus patients who did not. Even in patients with complete endoscopic healing of UC, fecal CarProtecting concentration can be used to discriminate patients with ongoing microscopic inflammation from patients with histological remission. The optimal cutoff concentration of fecal CarProtecting was calculated as between 75 at week 8 and 99 at week 52. Combined endoscopic and radiological healing or deep healing is reported to be associated with favorable outcome in Crohn's disease patients. In this study, in the 268 patients receiving anti-TNF therapy, the deep healing group had the lowest median fecal CarProtecting level. The optimal fecal CarProtecting cutoff level is 81 microgram per kilograms in predicting deep healing. Adding serum CRP and albumin to fecal CarProtecting further increased the AUC to 0.805. This study is a post hoc analysis of the Unity and IM Unity studies. The authors found that fecal CarProtecting of less than 250 milligram per kilogram after 6 weeks of treatment was associated with endoscopic remission at week 52 in patients with CD treated with ustekinumab. I think fecal CarProtecting is important in that it may be able to predict treatment response. The second topic is new biomarkers. This is leucine-rich alpha-2 glycoprotein, LRG, was identified as a novel biomarker for rheumatoid arthritis and IBD using proteomic approach. LRG is a 50 kilodalton glycoprotein containing repeated sequence of leucine-rich motif and expressed by hepatocytes, neutrocytes, neutrophils, macrophages, and intestinal epithelial cells. It can be measured within an hour at a hospital laboratory and covered by medical insurance in Japan. Serum LRG levels were significantly increased and correlated with clinical and endoscopic activities in patients with UC. Even if the comparison was limited in the patient with normal CRP levels, the association existed. LRG better differences mucosal healing in UC patients than CRP. This study investigates the changes in LRG over time during adalimumab treatment in UC and CD patients. As you can see in the graph, serum LRG level decreased with clinical and endoscopic improvement in both groups. The endoscopic activity was observed to correlate more highly with LRG than with CRP or fecal CarProtecting in the pooled analysis at all time points. This study investigates the association between LRG and small bowel region in CD using balloon-associated enteroscopy. Serum LRG levels were significantly higher in patients with modified SES-CD score of 4 or higher in any small bowel segment. The AUC for LRG was significantly higher than that of CDI or CRP. And this paper was published in this year Gastroenterology. Kuwada at colleges screened 23 integrin family proteins by ELISA in order to find UC-specific autoantigens antibodies. The results showed that anti-integrin alpha-5 beta-6 autoantibodies were detected in the sera of 95% of UC patients. This figure shows the result of validation cohort. This is a significant difference in the presence of anti-integrin alpha-5 beta-6 between each group. Anti-integrin alpha-5 beta-6 antibodies were present in 92% of UC patients and 5.2% of the control groups. Sensitivity and specificity are very high. This IgG inhibits integrin alpha-5 beta-6 fibronectin binding and may decrease barrier function and mucosal healing. Further validation is needed, but it must be useful in the diagnosis of UC. Also, this autoantibody is important in elucidating the pathogenic of UC. The third topic is prognostic and predictive biomarkers. This is a prospective longitudinal cohort study with new approach. CD patient commencing anti-TNF therapy were recruited. Feces, serum, and urine samples were collected at baseline and 3 monthly. A comprehensive analysis of metabolites and 16S ribosomal RNA sequencing was performed to find metabolic biomarkers associated with response to the therapy. This is a PCA analysis of responders and non-responders. Metabolic biomarkers involving lipid, bile acid, and amino acid pathways may contribute to prediction of response to anti-TNF therapy. In this study, the authors profiled serum proteins using the novel proximity extension assay to identify diagnostic and prognostic biomarkers in IBD. They made a prediction model consists of 5 proteins to distinguish a high-risk subgroup in IBD who need biologics, cyclosporine, or surgery. In recent years, the concept of treat target strategy has become widely accepted in the treatment of IBD. In stride to biomarkers such as CRP and fecal CarProtecting have been established as intermediate medium-term feasible treatment goals, and their importance is increasing. Fecal CarProtecting has been reported to associated with microscopic remission in UC and deep healing and treatment response in CD. Recently, several new biomarkers such as LRG and anti-integrin alpha-4 beta-6 antibody were proposed, but further validation is needed. Thank you for your attention.
Thanks a lot, Professor Junji Umeno, for this comprehensive and informative lecture. The floor is open for discussion. So we can say that the condition is somewhat stable. The CRP and fecal calprotectin are still the informative markers for IBD.
Yeah, I think so.
So all other tools are still under research. Okay, thank you very much, Professor Junji Umeno, and very glad to see you and to learn from you. Thank you very much.